I would echo Steve's thanks, and the same thanks comes from Ruth May, to say thank you to all of those who are working currently with the challenges and preparing for our new emerging issues. It's taking up a lot of infection prevention and control people's time, and EPPR colleagues, etc. So thank you to everybody who's working really, really hard. Steve really covered all of this. This is where I struggle here, because I've got glasses that I can't read there, and then I never quite know what you're meant to do. So I'll probably just wing this, actually, and won't use the slides, which is probably better. Steve alluded to the ambitions that we've got to reduce the gram negatives, but for me, the important message we need to remember is if every single one of those infections is a person, it's not data, it's about somebody who's come to harm, somebody whose life may not be the same again and indeed may die. So the focus on prevention is very, very important. So I think we need to always remember that if we can prevent an infection, we can prevent the use of antibiotics. If we have an infection, if we use the most appropriate antibiotic, we can prevent somebody going on then to develop a more severe infection and sepsis. So really, really very important. So we could debate targets long term, couldn't we? But I think the important issue is that we would all be aiming to reduce infections where we can and avoid harm to any person, wherever they are in our health and social care system. We know from the gram-negative programme that the focus needs to be on UTIs, and that's not going to be any surprise to any of you out there. So the focus in our long-term plan work and commitments to deliver to Steve as the Human Health SRO is to look at how we can work differently, and Steve alluded to that. If we keep working just in the silo of the acute providers, secondary care, we won't deliver those reductions across the whole system. And we have witnessed, as we've been around the country, and Rosie's here from my team, and David's done some of the visits as well, we've been across the whole of England and seen fantastic work where people are working differently to work as a system and to use other people's skills. I think the important message is most of this isn't an infection prevention and control problem or an issue. We need to think wider. We've got teams who work with frailty. We have teams who work with continence. We have lots of experts out there who, when we join together, we're a very powerful force. So for me, it shouldn't all sit in the IPC agenda, but think about who are your allies, who can you get to deliver some of these work streams. And Steve alluded to this as well. Think about when you're setting up an improvement system to deliver reductions in the gram negatives, and then hopefully we will be reducing the need for many antibiotics. Who are your allies? Who in that STP ICS who's going to work with you to help deliver it? Who are you going to work with from primary care? Who is your GP colleague? Who else would help you? Who in the voluntary sector are your key allies? We went down to a session when we were in the southwest, and one of the teams there had got a fantastic resource in place where volunteers were visiting people at home during the summer to help encourage them to drink more and keep hydrated during the heat wave. So it isn't always the obvious people who can help with the solutions, and it doesn't always come with a resource. And we obviously need to be working with our local authorities and our local councils, public health colleagues to deliver some of this. And I think there is a lot that fits around frailty. If we look at how the most of these infections occur in people who are over 85. I have to say over 85 because people talk about elderly over 60 and 65, and I think that's not old. So we have to think about who are our real risk audiences here. Steve alluded to this. I think language is very, very important. We debated the title of this conference quite long and hard, I have to say, and we were going to call it AMR, but some people felt that people think it wasn't infection prevention and control. So I think we do need to get it right about what is the language we're using and what do we mean by AMR. I think some people think it's antimicrobial stewardship, not the bigger umbrella of including infection prevention, stewardship, diagnostics, the management of sepsis. They all sit under there, as many other elements do. So first, we probably need to start with what do we mean when we're talking about AMR? And we all have a different view of that, don't we? So what is the language? We need to talk a common language. The work we've been doing centrally within the team within NHS England and improvement, and then working alongside our colleagues across the whole of England, I could tell you if I was on point list, it would be looking at rail stations and all things like that. Could travel the country up and down. We do know, I should say, that if we focus on the older people, and we focus on urinary tract infections initially, we will get more improvement. And trying to work on an improvement plan where we try and encourage everything. And we've been to some areas where an improvement plan is so big and cumbersome that nobody could actually begin to deliver anything. So as a system, work out what are your big risks, where is your intervention going to be, and how can you then focus on some improvement that you could measure to actually say what we did have an impact. We're not very good in IPC at actually saying what we did and what was the outcome, so let's stop doing that if it didn't work. The whole debate about community onset versus hospital onset, we know that the vast majority of cases have a positive blood culture on admission to hospital, but when we look at that data in more detail, we know of that proportion, 50% of those with a community onset have actually had a healthcare intervention in the preceding 4 weeks. So we do need to consider those interventions, and that's how we're defining the healthcare associated infections. Steve alluded to this. If we do nothing, we will see cases going up and up and up, and that's the dotted line. This is all cases of E. coli. This is not healthcare associated. The ambition initially was to follow that green line. We're not following that green line, but we haven't seen the incremental growth that we were seeing before. So something is beginning to work, we believe, and we work with some systems can actually show that they have got some good reductions. And I'm sure some of you are in the audience here, so please share what you are doing and how that's working. And I think the important thing I allude back to again, this is about a person, it's the impact on that person. There are costs associated with their care, the use of antibiotics, but severe implications for some individuals who then get a severe infection. The ambition or target that Steve said that we're looking at in the standard contract is not just for E. coli, obviously it's for the Klebsiella and it's for Pseudomonas as well. So it's the 3 organisms that will then form part of that reduction programme. And we're currently working that through and looking at the data with colleagues from PHE, as Steve said, to see what it looks like. And also to look at the variation across the country, and some people have already done significant reductions, so it's about how we make sure we've got a balanced approach. And none of us would disagree, I'm sure, that we need to be reducing infections where possible. We've been running a programme centrally. I'm not going to go through all of this because it would be quite boring, but the key message that we've been working with within my team is that people in the centre, the people in the systems are the experts. So it's how we work with you to look at what you're doing and how we can encourage and help that engagement. An example of that is the piece of work on the hand hygiene policy that's in the Scottish manual that we've adopted. A group of infection prevention control practitioners got together from a wide range of NHS organisations and have managed to get consensus. Now that's quite a challenge if you put 30-some so infection prevention practitioners in a room to get them to agree on something. That happened, so that's the beginning. And in the National Action Plan that Steve spoke about, there is the aim to move forward to adopting the Scottish Infection Prevention and Control Manual. Excuse me. And that, I think, has become even more apparent for me in the work we're currently doing with this, the coronavirus, is we have got such variation. Our Scottish colleagues are currently able to just refer to one document and say this is the policy we will be using, whereas we're not in such a strong position. So all of you that are interested, please come and work with us as we begin that next piece to move towards adopting that Scottish manual, because it is happening and it will be coming. That's probably the key piece from all of that, but the fantastic role in this team that I've had is visiting all of your systems, and you're going to hear from one of those systems later that Steve spoke about. The team from Kent are here, and they've come up with quite a radical approach to how they're dealing IPC within their STP. It isn't the same model that you and I are used to, so I think we're all ready for change. There's always change. That's one consistent factor, isn't it, in the world that we're working in. So the programme, as we move forward for this year, is looking at a priority is to get the national policy work scoped and get it ready to see how we adopt it in England and how that can be done pragmatically. There are differences in legislation in the 2 countries. A focus on hydration. There's some simple stuff that can be done with hydration that isn't complex and massive. So let's look at how we can implement some of that improvement work that many colleagues have already done, how we can adopt that and begin to spread. Steve alluded to this, we need to be working with the Get It Right First Time team. looking at what's in the standard contract. There was lots of debate went on about this. Half of the camp would say, we don't want a target, we know what we need to do. And other people said a target will help us, it will raise this to board level, rather than just talking about MRSA and C. diff. So, as always, there's a mixed view, but I do believe it will raise the profile of gram-negatives and the impact huge numbers of cases compared with C. diff and MRSA. And how we then continue to work with systems to develop improvement work. I'm going to skip that one. Another colleague in the team, Esther Taborn, has been working with a load of people from different areas to get some resources. Now, they are all available on the NHS website, so don't try and reinvent a wheel where you are. She's worked through a big toolkit of a wide range of resources that people have kindly shared with us all on the work they're already doing. It looks at improvement plans, it looks at the kinds of teams that you need to deliver improvements across the system. So please go there, please have a look at it. It includes people from health and social care, a wide range of resources are shared on there. Steve also alluded to the sequins that are coming out, so there is the one around prescribing, but there's also an important one in there about oral health, and I'm sure a lot of people working in IPC will have realised there's an important connection there. And the flu vaccine appears in there, so we will be preparing now for next winter, won't we? So don't forget, vaccination is still a very important part of infection prevention. So please use the resources that are in the gram-negative toolkit. If you find something on there that you disagree with, or you've got a better version, share it with us. That's really helpful. We have got, as part of the additional resources, we've got 3 colleagues who now work on that programme. Look at how you work as a system. Don't continue to work in a silo. And if you don't know the solution to that, go and ask people, spread and ask the questions. You do need to understand your data, and that is an important starting point to look at any kind of improvement plan and how are you going to measure improvement. Share your learning, and we do need to make every single contact count to reducing healthcare associated infections. So I'm going to stop there.